Welcome everybody. Just going to allow a few more minutes to let people join and then we'll begin. Hi Julie.
Hi Eleanor, how are you? Good evening everybody. Thank you for joining. I hope you enjoyed the session.
Got a good amount of people joining, so I'm just going to give another few seconds.
They're flooding in. It's like the floodgates.
Welcome everyone. Right, I'm going to begin. Well, thank you everyone for joining today and for joining the sixth session in our Exploring Eczema webinar series, and today we'll be talking about itching and scratching. My name's Eleanor Martin. I'm the Health Content Lead here at the National Eczema Society, and today I'm joined by Julie van Onselen, our lead speaker for the Exploring Eczema webinar series. National Eczema Society is a UK-based charity that provides support and advice for people affected by eczema. Alongside our wide range of information and advice, we use our collective voice to raise awareness of eczema, progress research, and campaign for better care. We've been working to make life better for those living with eczema for over 40 years, and we rely on voluntary donations to fund our work. We will be recording today's session, so you'll be able to watch back afterwards, but please don't worry, all participants' microphones will be muted and cameras will be switched off. Please change your screen name to anonymous if you don't wish for your name to be visible in the recording. There will be an opportunity to ask questions at the end. You'll be able to do this by using the Q&A chat feature. Feel free to drop questions in there throughout the session, and we'll aim to answer as many as we can at the end of the presentation. We have more webinar sessions coming up shortly, but I'll speak more about those at the end of the presentation. So today we're joined by our lead speaker, Julie. Julie's worked at the National Eczema Society as a clinical nurse advisor for over 20 years, providing support to thousands of members of the eczema community. She also has an impressive 30 years of experience caring for those with eczema in the NHS. Over to you, Julie.
Thank you, Eleanor, and good evening, everybody. As we say, this is our sixth in the series of 8 of itching and scratching. Previous webinars have included topics such as childhood eczema, emollients, managing eczema flares, and then ones to come are contact dermatitis with a focus on hands, and one on facial eczema. So hopefully we will have had something for everyone. But the topic tonight, itching and scratching, is really, really key because I think all of you know that everybody with eczema suffers from itching. If eczema wasn't an itchy skin condition, it perhaps wouldn't be as bad as it is for a lot of you. And of course, scratching is that response to the itch. So I'm Julie van Onselen, and I've worked in dermatology for 30 years. I've looked after many, many people with eczema of all ages, and I have worked with the Eczema Society nearly all that time as well, initially as a volunteer and then employed since 2007. I'm the clinical advisor, and I'm on the medical advisory board, and very excitingly this year, I'll be on the research group as well, as at the Eczema Society in 2025 is going to really look much more closely now at research. So there's lots going on with the Eczema Society and lots more to come. So what does this webinar contain? What are we going to talk about? Well, we're going to look at the theme of itching and scratching, and we're going to look at how to control eczema-related itching and scratching alongside treatments. So what makes itching and scratching worse? And again, that can be very individual. What makes itch better? And how to treat itch. And also, I'm going to actually discuss a little bit about behavioural techniques, a technique called habit reversal, which I actually have been trained in and have used with my patients over many years. Unfortunately, it's not that accessible in the NHS, but it certainly needs to be. But it might interest you, and it is a self-help measure that can be added in as well. So hopefully that will give you some interest. So we've always based all of these webinars really on the common questions that people ask on the old helpline. Unfortunately, we don't have the helpline running anymore, and this is precisely why we're putting resource into these webinars, because all of you out there. This is all the public who are interested in eczema, or people who care with people of eczema have common questions. So the questions we used to get a lot on the helpline were around these themes. Why does eczema itch? What does scratching do to the skin? What makes itching worse? How is itch treated? How do I stop the itch? And why is itching a problem at night? And how can I improve sleep? So we'll try and answer these questions and give you some practical tips alongside. So I think, first of all, it's really important to just distinguish between itch and scratch, because itch is actually an intense, distracting irritation, tickling sensation. I think that sometimes it's completely incessant, and also it can cause pain as well. And it can be felt all over the skin surface or confined to certain areas. But whatever it is it's incredibly irritating. And, sometimes people, remember one lady once said to me, the problem is the itch is incessant. I just can't get rid of it. It drives me mad. It dominates my life. And certainly untreated eczema, this is a very, very, severe and disabling symptom. Now, you sometimes hear medical people talk about itch as pruritus. So it's just a sort of, all these terms that sometimes healthcare professionals use. It's useful to know. So pruritus is a medical term for itch. And scratching, of course, is a response to the itch. So I'm going to talk a little bit about why itch occurs within the skin, but of course your scratch is the response. And the scratching is interesting, because the worst thing you can ever say to anybody with eczema is stop scratching. It really is. It just makes people even more frustrated. So what we have to do is try and help people, if you're caring for someone with eczema, to perhaps find distraction techniques to try and reduce maybe the habit of scratching, because scratching is a response to the itch, but sometimes can also be a habit. And if you excessively scratch and rub your skin, and sometimes this can be one area, you often see this in children, where one side of their skin, maybe a flexure on their elbow, is worse than the other. I have my own little expression for that, and I call it the comfort blanket area. So whenever the child's upset or crying or frustrated, they go into a corner and they just rub one patch. But this excessive scratching can also lead to this roughening of the skin. We call it lichenification. You can see the difference here between white skin and skin of colour. This is still an inflamed, roughened patch as white skin, but not quite, looks different on skin of colour. And that can also worsen eczema as well. So why does eczema itch? Well, it's complicated. Basically, there are receptors in the skin, within the skin immune system, and they activate on itch sensing nerve fibers. And these are called G protein coupled receptors, GPCRs. Don't worry about that too much. But what they do is they open a channel, and it tends to be a feedback channel that first of all feeds into the cytokines and proteases, which are part of the inflammation of eczema, the immune cells within the skin. It feedbacks, and then it feeds into these little sensory neurons, your nerve fibers in the skin. They send messages to the brain, and the brain then tells you to scratch the itch. So that happens for anybody who is itchy, whether someone has an insect bite, or even when you see your dog maybe lying on the floor and having a good scratch. So the brain perceives the itch and then sends a signal back to start the scratch reflex. So a little bit like when we were talking about the vicious cycle of eczema, the scratch itch cycle is a vicious cycle and needs to be broken. And of course, itch can range depending on severity of eczema. So eczema is a chronic condition. That's the first thing. And sadly, there's no cure, but research is really moving at a rapid pace. And you'll see a slide in a minute where we look at all the new drugs coming to the fore. And also a lot of these new drugs are acting on the immune pathways that actually are responsible for the itch. So they are really quite exciting. But you see, eczema can have sort of chronic periods where the skin is dry, and then, of course, the flared periods where the skin is very inflamed, thickened, bleeding, oozing, and you're in a flare situation which you need to treat. But then sometimes you can get this in-between area. We call it subacute. So Obviously, when eczema is more mild and not fiery and flared like this, the itch might be more infrequent, but it still can be there. And for some people, it can still be a severe symptom. So itch really carries on through all these. And of course, if you have severe eczema, you're going to have this incessant itch. And the more you touch and scratch your skin, in fact, the more painful it often gets, and you can damage the skin barrier and cause wet and weepiness. So really, I always say eczema is a series of vicious cycles, and what we need to do with treatment and self-management is try and break the cycles at every point. So it's a key symptom, and the itch is led by these inflammatory mediators. Inflammatory mediators cause the skin to be red and fiery, and that's your eczema flare. But when you have an itch and you scratch your skin, you actually open up more inflammatory mediators, which leads to more development of eczema, more dry skin, and then you get what we call the vicious itch scratch cycle. I sometimes also call it the itch scratch damage cycle, because when you damage your skin and you open your skin, you've then got a portal for more infection, microbes to go in your skin, and allergens and irritants. And that's why, really being very diligent with your moisturizing every day is just so important to repair that skin barrier. It's really important to try not to let your skin get dry, because it will crack, and that will cause, more entry of allergens and irritants into the skin as well. So that's really, what's going on. But of course, what does make itching worse? Well, I've already alluded to the dry skin and skin barrier alteration, and I'll talk a little bit more about that. I've already talked about those eczema flares, and I sometimes say to people when they say, well, why does my eczema flare up? I get it really settled, and I think I'm there. I've sorted my eczema out, and then suddenly it bounces back. It's often people might say, well, it's probably because I treated my skin and the treatments made it bounce back. And I say, do you know what? Unfortunately, 9 times out of 10, it's eczema, because eczema is a chronic condition. I sometimes say, think of your eczema a bit like the sea. The sea is unpredictable. You sometimes get a stormy period with crashing waves, and then the sea becalms. And lo and behold, the next day a storm whips up. So it is really unpredictable, and you get an idea of your individual flare pattern as well. Of course, environmental triggers are incredibly individual. There are some very universal irritants, which we'll talk about, but there are also individual irritants, which may also be allergies as well. So it's getting to know what triggers your eczema, and again, that triggering can start the vicious scratch itch cycle. And skin infections don't help either, because they can make the skin more severe, more flared, more itchy. So again, wet, weepy eczema, yellow crusts, don't put up with it. It's like your skin's infected and you need treatment. And then, the itch scratch cycle itself, which leads into some psychological factors, particularly with unconscious scratching, that you absolutely cannot help, because it becomes an unconscious response, and habit feeds into that as well. So when we talk about the skin barrier, we went through this in other webinars, so excuse me for repeating things if you've been to some of the other webinars, but we talked about it quite a lot in the emollient webinar. And I think it's really important to understand that eczema skin is often not as a normal barrier, because when you don't have eczema, you have skin that's rather like a nice cement brick wall. You've got even corneocytes that actually hold water, and you've got substances in the skin that help those cells swell and stay close together with this lipid lamellae, which is rather like cement around the cells. So think of a nice cement wall. Irritants and allergens can't get in, and moisture can't get out. When you have eczema, it's completely different. You don't have as many natural moisturizing factors. In fact, you're 80% down on them. So what happens is your skin cells shrivel up, and they become uneven sizes. And then the lipid which is surrounding them also breaks down. It's very microscopic, but what actually happens is that you have a barrier now that's letting in irritants, which causes inflammation and flares. and letting out moisture that causes the dryness and the cracking. So what we don't want this sort of dusty, broken down, dry stone wall. We want to use our emollients to restore that to a nice cement wall. More about emollients in a minute. And so eczema flares again is a vicious cycle that dry skin often is itchy. So I always say dry skin is itchy skin, and when you damage it, it becomes broken, it becomes weepy and sore and crusty and maybe infected as well. So again, you've got these three stages where itch can come in at various levels. And for some people, it might not be like that at all. It might be that your skin is always very itchy. For other people, when eczema is quieter, you have a bit of respite from itch. I think of all the skin conditions and all the people I've nursed with skin conditions over 30 years, I have to say eczema is one of the most individual conditions. So you always have to look at your patient, if you're a healthcare professional, and really ask them the questions about, you know, how often, how severe the itch is and what it means to them. And it's incredibly important to get that individual perspective and then tailor the treatment for that patient. So there are lots of triggers, and I'm sure when you look at this list, you say, well, everything triggers my skin, and absolutely, it might well do. But what we know is that some are irritants, such as soaps, detergents, the weather, central heating. They're not allergies, but they're irritants. But then, you know, the most common allergies, and in fact, if you tested everybody for eczema, everybody with eczema would be allergic to pollens and molds and also dust mites. But you cannot get rid of them because they're inside a house, and the pollen are always outside the house. So you just have to adapt. People might be allergic to topical products or makeups. Smoke and pollutants are big drivers, so it's important not to smoke around children with eczema and adults too. Some people may be allergic to their pets, but then it's also quite good to grow up with animals because there can be a little bit of sensitization, which is good. But if you know eczema isn't getting bad, you may have to have tests to look at that. You know, even irritant food on the skin, even some fabrics, and certainly stress, a big one, because we do know that stress also has a potential to drive this scratch itch cycle, which we're going to talk about now. So with the psychological factors and habit, I think the key thing is there are two types of scratching and eczema. One is absolutely due to the physical itch and the flare up, and one is due to habit that becomes a characteristic of long-term atopic eczema. And patients with atopic eczema often experience worsening of their skin when they're stressed. Again, I'm sure some of you are saying, yep, that's me. And what we know is that, you know, psychogenic stress actually can exacerbate and drive itch as well, which is quite interesting. And you can get an itch scratch anxiety cycle, and that can make itch worse and therefore make eczema worse. And 64% of adults in a study actually reported that a stressful life event before an eczema exacerbation and itch, which they felt was a contributing factor. So we do know this from research now quite clearly. The mind-skin link is very much there, or the mind-skin axis, we sometimes call it. So let's turn to more positive matters and look at maybe what makes eczema better. So I've talked about emollients. We did a whole webinar on emollients. The one thing I didn't say when I was talking about the skin barrier is that the reason that this skin barrier is such a problem for people with eczema is due to a protease called filaggrin. Now, this was only discovered in the late 90s, so not that long ago, about just over 20 years ago. And what was found out that 50% of anybody with eczema, even if they've had it from a child and it's a bit better now, they may still have the sort of dry skin that keeps recurring. And that's due to this protease deficit. So we know that 50% of people who've had eczema will continue to have a skin barrier defect for life. And in some ways, this explains why some children do, in inverted commas, grow out of their eczema, because eczema can always come back at any point in life. But it also maybe explains why some people maybe have eczema as a child, it maybe gets a bit better, maybe as older child, teenager, maybe it doesn't. Teenage eczema can be really difficult as well, but they have a sort of break where it's not so bad, and then it sort of bounces back. And again, that's due to the eczema and the this deficit of proteins in the skin and the barrier function, that the eczema really is still always there. So that sort of explains why sometimes it does just bounce back when people think they're rid of it for life, because unfortunately, as a chronic condition, you aren't, unfortunately. Psoriasis is very similar, if you want a comparison. So emollients are really important to just constantly treat the dry skin. Dry skin's always itchy skin. To repair the skin barrier in itself, emollients relieve itch. They're the single most important treatment for relieving itch. And the problem is, it's if you do use an implement to scratch with, even if it's a soft implement, that rubbing action will still keep sending those signals to the brain to turn on the itch. Whereas if you use a moisturizer, perhaps particularly, you can put a moisturizer in the fridge and use it cool, and you dot and stroke on, a very gentle with no irritating ingredients, you can actually help turn off those itch sensors. So it's quite important, and it's really, really hard for you, and if you're a parent with your child, to try and sort of reduce scratching or rubbing as much as possible. So in terms of applying emollients, a lot of people instinctively think you rub creams in because it's just an instinct, a human instinct. But actually, it's so much better if you dot the emollient on the limb and you stroke, and you actually just smooth in the moisturizer all over that limb. So dot, stroke, smooth. Just changing that can actually really help, because any amount of rubbing in circular motions, or gentle rubbing up and down, again, it sends those signals to the brain and can start the itch again. So when we treat flares, and when eczema's flared and intensely itchy, and remember, topical steroids are short-term treatments. Your emollients are your long-term, day in, day out, ongoing treatments, but steroids should always be short-term. In that way, you won't run into trouble. You run into trouble with steroids, basically, if you use too much, too strong, too long. So if you have a child with very flared eczema, very itchy, not sleeping, for example, and you're worried about using a moderate or strong steroid for 2 weeks because of side effects, you'll probably get more trouble by not treating the eczema, because the eczema will get worse. And remember, we do prescribe steroids very carefully. I treat them with the greatest respect. They are drugs, but they're topical drugs applied to the skin. Of course, they're not going to cure the eczema, sadly, because eczema is a long-term condition, but they do give respites in between. Again, you can compare it to somebody with asthma who has to use their flare inhaler for certain times, and then use it as preventative inhaler. So you can see the same with eczema. Maybe your preventative is your ongoing emollients, but you use the eczema for flares. So again, we would match all these groups of steroids quite carefully. And mild is very mild. Moderate is still pretty safe to use, again, in short periods. But if you need a strong steroid, you'd use it, and then you would come down quite quickly within a two-week period, sometimes a bit longer. We had a whole webinar again on steroids with a lot more detail. But what we generally say is that when you have eczema, you have a fire. So basically, your skin's on fire. So I always say you need the right fire extinguisher to put the fire out. So that's why you need the right strength steroids, and you also need to use enough steroid to treat the area. Once you've taken out the fire, like any fire, you're left with the hot embers, and those embers can actually spark up again. So generally, again, that's the eczema that comes back. So you need to keep control by stepping down. So you would use topical steroids generally 1 day a week, and then step down to every other day. But for some people with grumbling eczema, sometimes steroids are used on 2 consecutive days a week for this sort of step down weekend therapy, which is very well researched. We also use other treatments called topical calcineurin inhibitors, which are fantastic maintenance treatments. They work on the eczema immune system, but they're not steroids, so there would be no danger of any skin thinning or as well. So that's useful. But then if you've really got your eczema under control, then you just stop your steroids and continue with your emollients until the next flare comes along. And unfortunately, a little bit like the sea, it's unpredictable. We don't quite know when that will be. Now, as well as steroids, I thought I'd just put in this quite complicated slide about the incredible research and development in eczema. I think it's really eczema's time, and I think the really important thing, so I'm not going to go through this slide, but what it's saying is that eczema is a complex condition. It's a complex condition with many immune immune responders, a lot of these ILs and T cells. And what has been developed are these whole biologic drugs called the MAB drugs that basically are blocking and acting on the immune pathways to literally turn off eczema. Now, we don't have all of these drugs in the UK because this is an American slide, but we're building up and we now have about 5 biologics and JAK inhibitors. The first one being dupilumab, which really turned off IL-4, and IL-4's an interleukin, which is largely responsible for itch. So people with very severe eczema were then being prescribed this, and there's some people are still on it, and their eczema is well controlled. And one of the wonderful things was the sort of complete turn off of the itch. Now, again, just like topical treatments, not every treatment works for everyone. So what works for one doesn't work for another. And sometimes many things have to be tried. Again, you can relate that to something like a condition, something like arthritis or inflammatory bowel disease. You know, those patients with chronic diseases, they all have individual therapies as well. But it is eczema's time, so I think there is so much more choice. So I would say that don't soldier on with your eczema if you keep getting lots of flares and you're not getting it into control. You do get to a point with more moderate to severe eczema where literally the topical treatments are just not working anymore because actually you need more advanced therapy. So still do ask to be referred. Now, people often say, well, what about antihistamines? Surely they help itch. Well, interestingly enough, especially by seeing that slightly complicated diagram, you can see that the mediator for itch is more about the complex immune system, and histamine doesn't really play much of a part. It's a bit controversial. H1 is the main histamine receptor we know. H2 is more related to buildup of acid and gastrointestinal conditions. And there is H3 and H4 receptor roles as well, and they are currently being researched. So what we're saying is that some people might find antihistamines helpful, but actually, in effect, a non-sedating antihistamine does not really act on the itch of eczema. You know, you're much better to use more emollients. The only exception is if you have a coexisting rhinitis or hay fever, and also if alongside eczema you get a condition called urticaria or hives, where you have wheals on your skin and that relates to allergies. And for hives or urticaria, antihistamines actually are your first line management, and they're often given in actually doubled or even tripled up doses. So, of course, you can do things to reduce itch triggered by environmental measures, and certainly, you know, there are some tips here. We have a whole fact sheet called household irritants, so do have a lot of that. You know, looking at temperature, not having environments too hot, not moving between hot and cold, definitely avoiding nighttime overheating. There's quite a lot of research that says when people with eczema sleep or at night, their body starts to overheat. And again, heat causes the skin to dry, and that causes more itch. Try and keep your water tepid when you have showers and baths, and always use emollients in your bath as well, because even plain water can have a pH of 7+, and again, that can cause more drying. But if you add emollient on, you can have very happily a daily short bath or shower, and that therapeutically is a great thing to do before bed to really settle you or your child. You know, look at natural fibers, avoid rough seams, because something even like a rough seam can be a trigger. Make the bedroom a very relaxing place. Look at sleep hygiene, which is really important. You know, don't look at screens, you know, before you go to bed. You know, try and have all that in place. And studies in adults have shown with itch and sleep that scratching often occurs in the earlier stages of sleep, and wakefulness then occurs after a bout of scratching. And I think, the interesting thing is that people with eczema, they often scratch in their sleep. You wake up and there can be blood on the sheets, and even babies can learn. So you can sometimes sleep through a bout of scratching and do damage. So this is when wraps and bandages are particularly useful, particularly for children. They feel a bit old-fashioned now, but they're not. I still think they have their place. So again, if eczema is quite well controlled, ideally don't use them with steroids, use them with emollients only, and maybe that point where particularly a child is then starting to scratch at night and having scratching bouts, because what they will do is they will protect the skin from then triggering that itch tract cycle again. I mean, you can use them with mild to moderate steroids, but only under supervision, because under occlusion steroids can become stronger, and you have to be really careful with infection, because infection can be worse or spread. But their main purpose is an adjunctive therapy, so they're not a therapy in themselves. Paste bandages are really messy, but actually they're really soothing. The Icfamol bandages or the PV7. So we use those a lot in the past, not so much now. And wet wrapping includes a wet and dry layer, which again can be quite cooling and quite helpful. Now we have a whole booklet on our website on wraps, bandages, and therapeutic clothing. So please do have a look at that. So now to talk a little bit about habit reversal, which is a behavioral technique. And as I said, scratching over time becomes a response, and almost an unconscious response. You almost don't know you're doing it. So it can be a habit of mental state as well. And again, it is something that you cannot help. You just sometimes don't know you're doing it. It's a little bit like nail biting or something like that. Maybe some people just don't realize they're doing it. And it actually means that if you scratch, particularly in those chronic times outside the flares, that this can actually drive and start another flare again. And you need to sort of try and address and try and look at changing habits. Changing habits is a key thing in lots of health promotional work. A good example is if you go on a diet, you change habits of what you eat, or you change a habit to drink 8 cups of water a day rather than none or 2. So remember that itch and scratching relate. The dry skin causes itch and inflammation, but then scratching can be a habit and can relate to mental health. And as I said, anxiety can also drive this as well. So there's quite a lot, which is important to just think. So I think it's a good idea to just maybe take some time and think about you or your child's scratching behavior, and just think about through the day, when I wake up in the morning, and I go and wash, do I immediately, scratch as I'm washing? I'm at work, I'm concentrating on the phone. Do I start unconsciously scratching? Or when I, about to get dressed, or I take clothes on and off, or before I go to bed, is it just a habit to have a really good scratch? So scratching behavior is really important. And it's just fascinating, really, because when we do habit reversal, we ask quite a lot about scratching behavior. And the consultation is really interesting because it's really quite different to a normal eczema consultation. So we call it the combined approach. And we do combine it with conventional treatment, because habit reversal alone will not prevent the eczema. You've still got to treat the flare appropriately and correctly. But what you do is on a first assessment, rather than assess the eczema, you actually assess scratching behavior. So you don't change anything. You don't change emollients. You don't talk about steroids. You literally talk to the patient and get them to focus on scratch behavior. And what you're doing really is you're moving patients from a more unconscious way to a conscious understanding of scratching behavior. I mean, another good example is it's a little bit like when you've been driving for a while and oh dear, you have that first little bump. When you first pass your test, you're driving in a real conscious way and aware of all the hazards around you. But then you sort of relax. And the most dangerous time for drivers is apparently 2 years after passing their test. You relax, and then suddenly driving becomes unconscious. You suddenly think, oh, how did I get home? Because it was a familiar route. And it's a bit the same with scratching, that scratching in that way becomes an unconscious behavior. So what we need to do is we need to get people to actually raise the awareness of when they scratch, because if they know the times when they're scratching and damaging their skin, and if they can undo that habit by other means, that means that in the chronic stage, the eczema, the skin is much more likely to heal, and actually that can prevent flares coming back so quickly. So we use a hand tally, a little bit like farmers use to count sheep, I sometimes say. And what we say is we say, don't change anything, but every day keep the hand tally in your pocket. And whenever you go to scratch or rub or touch your skin, just click the tally. It is it's amazing. It's so fascinating. And we do this, morning, lunchtime, afternoon, and evening. And then we get an idea that, maybe some people scratch, 100 times in the morning, but then when they're sort of occupied at work, they probably scratch 50 times. But you build up an idea of when scratching is most prominent in someone's life, and then they literally just raise awareness. So when they fill in the form, they're absolutely amazed by the count on the tally. And then we say, well, now we need to think about the times when you're scratching the most, and can we change any habits? So, for instance, if it's just scratching skin when you're watching television at night and you're a bit tired and relaxing, you might say, well, you need to do something else for your hands. One patient I knew did really well, and her eczema got an awful lot better because she realised she was just watching television and fiddling and scratching and rubbing and exacerbating her eczema. And she took up cross stitch. But sometimes it can be simple. You hold your hand tightly, you make a fist, and with children you can play games. The other thing is, when you itch, it's quite a good idea to just pinch the itch rather than scratch, because if you pinch, you actually trick the skin into a pain sensation, and that can turn off the itch as well. And then once you sort of establish that and you've done some reversal, you then put in the correct topical treatment and get the eczema treated alongside. Now, there are not many healthcare professionals who practice this, and it's such a shame. It really should be out there in primary as well as secondary care. There is a book. I think you can still buy it on Amazon, or maybe you can order it from a bookshop, which is called which is a self-taught book of habit reversal. So it's something you could look at yourself, but you may find a healthcare professional. It's good to do it for healthcare professional because you actually get that support as well. So that was really now the end of the session. Sorry, I finished slightly earlier than I thought, 5 minutes earlier. I was aiming for 45 minutes, but it's quite a full session. But the main thing is that we're now going to open the floor for questions, and I'm sure there might well be many. So or maybe there won't. Let's see. I'm going to have
Thank
some
you, Julie.
water because I'm drying
Brilliant,
out.
that sounds good. Yeah, so feel free to pop any questions in our Q&A chat feature there. We have had one come in, so please keep them coming. But to start us off, Julie, we've had a question that says, I've had an outbreak of eczema and itchiness due to starting running, likely sweating in tight clothes. I tried to prepare my skin before running by using Balneum Plus in the areas where itch is the worst. Do you have any tips on this?
Oh, yes, no, you're absolutely right. That's a very good example, isn't it, of an individual trigger. Unfortunately, sweat is quite an irritant to skin, but then it's so good, you're keeping fit and running. So we've got to strike a balance, haven't we? And yeah, I think you're right. Certainly, it's good to make sure your skin isn't dry before you run, but also the only thing I'm kind of thinking of, and I think what you're doing is right, and that might work for you, but if you moisturize quite well before you run, sometimes the moisturizer can actually sometimes block the sweat pores slightly. So when you run, you produce more sweat. So it might be better actually to actually run before you moisturize, and when you come back, have a nice emollient bath and emollient. You could be blocking your sweat follicles, and that may be a reason. It may not be. Obviously, it's what works for you. And Balneum Plus, by the way, I should have said, some emollients contain extra ingredients to help with itch. And Balneum Plus contains a local anaesthetic called Laura Macrogols. And there are also Mefoderm and another Dermacool as well that contain menthol. But a good way of actually helping your moisturizer to actually be more soothing is actually put it in the fridge. I would always say never warm emollient. That can actually affect the formulation. And again, warm emollient is not great either for itch. So cool the emollient and get an emollient to suit you. But maybe that's something to try. Maybe focusing on the emollient after the run rather than before the run. Yeah. And of course, remember you can apply Bounty Plus all over your body to everywhere. You don't have to just target it on the eczema.
Thanks, Julie. That's really great advice. This is a bit of a long one, so bear with me. My 23-year-old is AUDHD and has sensory issues with emollients. Frustratingly, he is also sensitive to cetyl preservatives in creams, which means he relies on more oil-based emollients, which is more sensorily unpleasant. It's a bit of a struggle to find emollients without aggravating preservatives. He was on immunosuppressants from 16 to 20, and I'm wondering whether he might need to go back on these, as his itch has been constant this winter. Can you recommend emollients without these preservatives, please? Many thanks.
Yeah, I mean, it's a really good question. The only emollients that don't have preservatives are the oil-based because the cream and the gels have to have preservatives. Otherwise, quite simply, the creams would go off. Now, a lot of people are fine with preservatives. A small number are allergic, and you mentioned about cetyl sterol alcohol, I think, or cetyl. A common preservative in loads of things, actually, washing up liquids, soaps, which you wouldn't use, but in lots of things for people. I think the first thing is to, I'm sure he probably has been patch tested, but in this case, I would say it's well worth asking for an appointment with a dermatology for patch testing, because then you can just really find out what is the preservative that your son may be allergic to. Obviously, alongside with the sensory issues, it's very, very hard because certainly, with people with neurodivergent conditions, with the whole spectrum and things like that, there is a real sensitivity issue with touch and feel on the skin. You could maybe try gel, because gels are pretty moisturizing, but they have a different texture to creams and lotions. So there are some emollient gels. And if you look at our website, our emollient fact sheet has a list of different formulations. Even a lighter lotion that's applied more often, but often if skin's very dry. But I think if your son did have immunosuppressants as a teenager and he's 23, it's again, as I say, the increase in the choice and development of the sort of the biologic and the JAK inhibitors. Obviously, it depends on the dermatology assessment, and it does also depend on national guidelines from NICE. He may have to sort of have a course of immunosuppressants to be eligible for them. But again, especially for somebody with sensory issues, it could be that really he needs reassessment with a dermatologist and maybe considered for some of the advanced therapies. Again, if you look on our website, you can have a read about some of these different therapies, the biologics and the JAK inhibitors. The biologics tend to end in ABS or NABs, and the JAK inhibitors are BIBs. They all have really complicated names, which are difficult to say. But we have quite a few fact sheets on them. I would definitely get another referral. I think, 8 years on from being 15 and on immunosuppressants, it would be good for your son to be referred again by dermatology. Sorry, a long answer to a long question.
And that's perfect, Julie. That's why people come to these, so they can pick your brain. So thank you very much for all of that. We'll move on to the next one. My 4-year-old suffers badly with eczema. It's gotten worse over the past couple of months. We had blood tests done to see if he has any allergies. The tests have confirmed that he is allergic to almost all food types. They list pretty much everything. The list goes on. So we have cut all these food groups from his diet. It's been 28 days now, but we've seen no improvement on his skin. Can we assume his eczema is nothing to do with his food allergies?
Yes, no, that's a really interesting question. I mean, I suppose the first question is, um, hopefully, but did you see an allergist, as in a medical allergist, a doctor who's an allergist, or a dermatologist for those blood tests. Because there are, there are some high street providers, just say that as a wide thing, who sometimes offer private blood tests, and they sometimes can give you a whole list of foods, and it's quite difficult because you think, well, where on earth do we start, and what can he eat, and can he really be allergic to anything? So I think just be slightly wary. I think if it is a real problem and food allergy is a problem, I probably would actually direct you to go to the helpline of another support group called Allergy UK, who are really, really good on the whole sort of allergy, and they have a helpline running as well. So I would actually say have a word with them on the helpline, because to be normally with food allergy related to eczema, you're allergic to a food group, but not many food groups. So it's difficult to just work out what's going on. And certainly if his eczema is no better, because food allergy is either an immediate IgE response, so or it can be a non-IgE. With non-IgE, you tend to get other symptoms. You get diarrhea and colicky and tummy pains and things. But if he's sort of quite fit and well, and or if he hasn't had an immediate response, I think it might be worth seeking possibly another opinion. But obviously, if you have been to a medical allergist or a dermatologist, you probably need to go back for more advice. As I say, it's difficult to know where you have been accessed. And as I say, children with eczema can have food allergies alongside eczema, and children with eczema can actually not have food allergies. So food allergies complex. I personally think you should give Allergy UK a ring, because they're very good on the general food allergy side. I'm sure they won't mind me telling you all about it. So I would contact Allergy UK for a bit of support from a support group.
That's great, Julie. I just want to say there's a question here. It's from an anonymous name, so I can't read your name out, unfortunately, but it begins, my son is always itchy. He has near permanent rhinitis. I'd say what Julie has just said applies to your question too, and to definitely seek out help from Allergy Advice. They have lots of great information and resources, and to also go back to your GP and maybe seek an appointment with an allergist or a dermatologist as well.
Thank you.
Next question.
Thank you very much for that person. You're absolutely right, because allergy is just such a huge area, and allergic rhinitis is, and as you say, we have close links with Allergy UK, and we always sort of recommend each other. And I know the two nurses, Amana and Margaret, who work there as well pretty well. So we work together.
Brilliant. Another anonymous question here. I see a lot of natural balms available on Facebook claiming to help. Are these worth trying? They are quite expensive. Also, any tips on best creams for post-swimming?
Yeah, no, great question. Yes, I think Facebook, you do get quite enticed by these we call them dream creams, as a sort of affectionate title. I think the problem is you don't know how they've been made. You don't know who've made them. You don't quite know what's in them. And I think the thing is, with eczema, you really need to keep things bland with, reduce irritating ingredients, and particularly increase fragrance. Now that contains essential oil. There's a lot of contact allergy to essential oils, even though essential oils feel natural. So I think the thing is, the word natural is quite a wide word, and natural. I actually think medical emollients myself are quite natural, because they don't really have much in them, but some people might dispute that. So I think it's just quite difficult buying something online where you don't know much about it. I mean, if you can buy something and you've got an ingredient list, and you can match that with what you are or may not be irritated or allergic to, maybe. The other thing is, they tend to be really expensive. So you sometimes, let's say you might spend £10 on a little pot of cream that maybe is 20 mils, whereas with emollients we say you need to use 500 500 grams a week, and they tend to come in much bigger pots and tubs. So again, you know, if it's an emollient, you need to use lots of it. So it could be very expensive. So I think, you know, emollients are individual. You've got to find one to suit you. But I think if you're going to be spending vast amounts of money on small pots of, you know, so-called natural creams that are just going to be expensive and not, you know, not going to be able to use in large amounts, it probably isn't worth it in the nicest possible way.
Brilliant. Thank you, Julie. My 10-year-old daughter cannot seem to stop using steroids, and despite seeing 3 GPs, I'm still unclear how to taper. Any advice?
I think get referred to dermatology. You know, that's exactly the point where, and I work in primary care and I was a sister in dermatology. You know, you need to have a proper assessment and other options really, because, you know, you can get to that point. Of course, there's much more to say, and if you haven't seen it, it might be worth seeing the webinar on topical steroids. You know, I don't know how old she is, but if she's still being prescribed a very mild or even a moderate steroid, actually just stepping up to a stronger one, you'll probably find you'll use a lot less of that and can step down. But I would say if she's seen 3 GPs and you're not winning, I think it's important to insist that you are referred to dermatology, because eczema is a difficult condition and a lifelong chronic condition, and you need the help if things aren't working from your GP. So yeah, you know, I would definitely ask or insist perhaps, and you know, I wish you all the best. I mean, obviously the waiting lists are very long. I never would necessarily advocate people to have to pay out their own pocket, but it may be worth it as a one-off just to get things under control. And if you choose the dermatologist who maybe is your local dermatologist, you may just need one appointment, and you know, then you could continue with the NHS. But as I say, it's a hard thing to advocate, but waiting lists can be up to a year, even a year and a half in some areas, which is just awful at the moment. So, but I would just start a referral.
Thanks, Julie. We'll try and squeeze a couple in quite quickly. My son is on a lot of strong new steroid creams. The last treatment did not clear the flare. I'm interested in wet wrapping, but as we are on the new program of steroids, do I need to ask the GP to be able to do this alongside? We didn't even make it to a steroid maintenance dose before it needed to be reviewed again.
Yes, again, just sounds a bit out of control, really. The other thing I should say is, you know, it's worth talking to your GP about, maybe if you have steroids, then reducing down to topical calcineurin inhibitors as well, because there are other options. But it's very difficult to sort of comment again on individual situations, but without knowing how much you're using, what strength you're using, and why it isn't under control. You could ask about wet wrapping. It's possible the nurse in the surgery might be able to help you. As I say, you can always look at our booklet we have on wet wrapping, which does give, you know, full instructions of how to do it. But you would need to be prescribed the garments or the tubifast. But it's really important that you don't do it if there's any sign of infection, and also you really shouldn't use it alongside with you know, steroids without medical supervision, and certainly, you know, the wet wraps can increase the potency of the steroids, so we generally do it without steroids. But yes, no, it's really difficult. I think another one who perhaps it might be worth asking for a referral to dermatology as well.
Yeah. Thank you, Julie. And the last one here, our consultant has prescribed Cetraben emollient for the whole body, but I'm wary of using it on the face as it's very thick. There are emollients made especially for the face. Do you think it is better to use different emollients for face and body? Thank you.
Yeah, I mean, it's a good question. Again, it's personal choice. Absolutely fine to use it for the face. There's no contraindication. It is a bit thick, so maybe maybe it's best to use it at night. And you could, in fact, Cetraben make a lotion if you wanted a thinner version of Cetraben for the face. So you could, and with emollients, sometimes people have more than one formulation. Sometimes people like an ointment at night, a cream in the day. Sometimes people do like a different formulation on the face. You could also maybe try some of the other lotions for the face, which are lighter. There are other brands that do lotions. Aveeno does a lotion, Aproderm does a lotion. I try and throw out more than one product. And again, if you look at our emollient fact sheet, you'll see those lotions listed as well.
Brilliant, thank you, Julie. And our last question, I'll be able to cover myself, is Cradle Cap and Eczema linked? We have just shared a lovely informational piece on all of our social media channels. So there is a possible suggestion that if your child suffers with cradle cap at a young age, that yes, they might go on to develop atopic eczema, but please do take a look at that guidance and you'll find more information there. I just want to say thank you, Julie. Now I'm going to wrap up our questions and just finish off here. Well, thank you, Julie. As always, very informative, a very useful webinar. And to everyone that's joined today, and if you're new, thank you for coming and welcome to our eczema community. We hope you have been able to gain a lot from today. Managing eczema can be very difficult at times, but we hope we've been able to provide some useful information and guidance. As Julie has mentioned, we do have a number of downloadable fact sheets on many topics on our website. So that's eczema.org. That can help support you through your eczema management. If you do want to become more involved with what we do at National Eczema Society, you can sign up to become a member for an annual fee of £25. Within that, you'll get a free subscription to our Exchange magazine, which you'll receive 2 of each year. You can also sign up to receive our monthly e-newsletter, where you'll hear about the latest eczema news, events, and information to help you self-manage your eczema. We do rely on voluntary donations, and as always, anything you can spare towards our cause will be greatly appreciated. And there's one more group I wanted to quickly flag here. The National Eczema Society has recently launched an Expert by Experience group. We aim to ensure that all the perspectives and experiences of patients living with eczema are considered in all aspects of the Society's work. We are looking to recruit more members to the group, and we're keen to hear from parents or carers with children from the age of infancy to 14 years of age. So if you are interested, please drop me a line. My email is on the webinar's webpage, but it's emartin@eczema.org. But thank you all again for joining. I just want to let you know that we are featuring a couple of more topics in this series. The next one will be on hand eczema, and these will be on Monday, the 17th of March and Thursday, the 20th of March. Registration is now live on our website, so if you want to head there, you can find information on how to register and the information about our previous topics. Thanks again for joining, and we look forward to hosting you next time.
Yeah, thank you very much, everyone. Thank you so much for all the questions. And I'm sorry to hear some of your stories as well, because it does sound like some of you are struggling. So, please go back to your GPs. Please ask for referrals if need be, and please keep in touch with us. But thank you. Just amazing questions, really, really interesting. And I think they will have helped and supported others as well.
Absolutely.
Okay, night, everyone, anyway.
Bye all. Thank you.
Bye.